Okay, so let's go ahead and get started. Good morning again. So we're going to start this session, start today off with a presentation on maps. And I know that a lot of you probably a bit tired. We're starting early, and some of you probably woke up this morning at 3 a.m. with the sun shining directly on your face. Or maybe you went out after beer and pizza yesterday and didn't get back to your hotel till 3 a.m., which is probably more likely. So I'm going to give us a quick introduction to this and give you some prompts to think about while we're going through this presentation. So my name is Scott. I'm the Analytics Product Manager. And then we're also going to have Björn, our lead maps developer, come up and give us an overview of the new functionality. And then we also have Maria Munez and Sylvia Wren from UNICEF joining to give us finish off the presentation with a little bit of information on how people are using maps and how we can encourage people to use maps more through capacity building. But to the prompts, so we know that the Maps app is probably one of the most underutilized analytics apps that we have in DHIS2, which is a true tragedy because it is an incredibly powerful tool. Of all of our apps that we have, it is probably the most advanced in terms of functionality. And because it's so advanced at this point, it's actually, somebody's still waking up. But because the Maps app is so advanced, I think that it's actually been very hard for people to keep up with the functionality because we've been pumping out a lot of functionality continuously. And so we're going to catch you up on that. So we're going to look at the new features. So please pay attention to the new features. This is not the Maps app that your parents were using. This has really advanced quite a lot over the last years. But I also want you to think about, as we're going through the Maps app, think about why many countries are underutilizing the Maps app. Is it that the functionality is not there? Is it that you don't have the capacity building? You don't have the strengthening? You don't have the use cases? What is it that is preventing you from using the Maps app? And then I would love to hear about that. We have a session this afternoon? Wednesday afternoon, where we're going to go into more detail around map use. And we'd love for you to come to that session and talk to us about why you think people are not using maps. And we'd like to figure out a way to move forward together as a community. You're going to see some examples of how people are already using maps, especially from Sylvia and Maria. And I think this should be inspiring to you. I think that you should see how some of these countries have adopted maps and know that you can do the exact same thing. There's no reason that you can't. Then we also want you to make sure that you understand how it takes a bit of more understanding on how we build capacity around maps. It's not like you just plop someone down in front of a map, a blank Maps app, and expect them to get it right away. Maps as a concept is a bit more advanced than, say, like a bar chart or a line graph. These are really simple things that most people can understand right away. But once you do build capacity around maps, it can be the most powerful analytics tool that you have. So with that, I think I will go ahead and hand it off to our lead maps developer, Björn, and he is going to take us through the latest functionality.
Thank you, Scott. Sometimes, like the Maps app is underutilized. And sometimes we hear that maps are looked upon as being more complicated, even so complicated that people are sometimes just afraid to go into the Maps app and try to make one. But just to get everyone here on the same track, the Maps app is super easy. I would argue that it's even easier than the other analytical apps. It's very, very few selections you need to make before you have actually created a map, and I will show this. But this is just to get all of you on the track. If you haven't opened the Maps app before, I hope everyone has. This is what it looks like. You can select the base maps, you have the legend to the right, and the most important button is the Add Layer button, where you have these layers presented. Then you have thematic you use for your aggregate data. You have events and tracked entities you can use for individual data. And then we have two layers that you can use for your org units. One is specifically tailored towards the facilities, the lowest levels, and one that can show the full hierarchy. In addition, we will spend quite a bit of time of these external layers here, which are fetched from the Google Earth engine, but they are from various sources. And just to show you the proof that you can create a map in 15 seconds, that will be showing now. I had an issue that, set the base map if you need to change it. Click on add layer, thematic. So the only thing you basically need to select to have a map is to select an indicator and then go with the default. And you have the map here and you can interact and click with it. So it's that simple. And then, of course, later on, you can go in and change the different period, change to different org unit, different district, and you can change the styling, and you can even filter the data if you want to look at part of it. But just to get started, select an indicator, click add layer, and you have a map. We've added quite a few features. I'm not going to go through this list. I'm going to present some of these features today. It's not only the latest features, because we have been building some of the features built on the others, and now we have a full package that we would like to present. Often also, I've quite a few times I'm presenting the latest features, but I also very often see that it's of no use because you are maybe 2 or 3 or 4 or 5 versions behind. So the good news here is that most of you later today can go and create its maps. You don't need to wait for 240 to be able to do this. So just start playing with the Maps app. The most important feature for 240 was a feedback we got when we had a workshop in Nairobi. You will hear more about it. And that was that printed maps are the main way of sharing information in many countries. So if you have a maps you would like to share with others, you could even make a PDF, but very often a printed map is what you would like to share. And the printing functionality in DHIS2 maps was very limited. And we have improved that greatly in this version. Another important feature, I know has been requested by many, was that it was only possible to display the name of the org units on the map, but you also wanted to see the actual value. And we have added that support now in 240. But what's different in this 240 is that you can click on the download, and then you are entering this download mode. And here you have lots of more possibilities to present your map. And very often the one who are going to read your map is a different person than you who produce it. So it's important to tell the story around the map and not only present the map in itself, because it can be hard to interpret. So what we've added is you can add the title and the description. This map is showing birth attended by skilled health personnel. It's in percentage. This is from the Sierra Leone database, so it's only demo data. And then you can select which kind of elements you would like to have, but these are like the basic. So you can have a title, description, legend, and inset map can be important for people to realize where in the country it is. We have a north arrow, scale bar. Yes, that's it. Here also, if you please get feedback. Give us feedback if you would like to have more elements to this print layout, and we can add it. So this is the result, quite clean map with a clear message. Often you have this, when I see maps that are produced, some of the maps are often too busy, because in the Maps app, you have the power of adding as many layers as you like. And sometimes that can be a great feature, especially if there is a linkage you want to show between the 2 layers. But instead of they come to with a cost, because it gets much harder to read. So instead of trying to put everything in one map, rather make multiple maps like this, which is easy to read, and maybe put them side by side instead. An important feature we added in 235, which I think most of you should be on now, is that for aggregate data, we only had this thematic mapping technique, which is called a choropleth supported. So this one here, the districts are colorized according to a statistical value. And this is a great map to use if you want to see data that is normalized per capita percentage. But it's not the map you should use if you show raw number, total population, or the number of births in the districts. And the reason is that you will easily start to compare the different districts here with the performance across the boundaries, but it's not really telling the true story, because often the raw data is connected to the population, to the numbers. And that's why you should also always use this, we call it the bubble map. It's often called the proportional symbol map. So please use this one. Normally, this is the one technique you use for data elements, and this is the one you use for an indicator. Changes are not only in space, they're also happening in time. So we have added 2 methods to show difference in time. So the first method is to have a timeline showing under the map. And then you can see this is for the last 12 months. This one is just playing, but you can also click on this different to move back and forth. I think the problem here is that if you're interested in one district, you should be able to just focus on that district and see the changes. But as the map as a whole, I find it very hard to remember how it was the last month when going to the next. So that's why we also added this, we call the split view, which I think is much better. It comes with a cost because it's less room for each map. So for example, on the last map, I could also show the name and the value. Here is only room for the values for the district, but here is much easier to compare the districts and the different performance throughout this 6-month period. Another feature we feel is underutilized is the event layer, which has many more styling capabilities now. So when you select an event from a program and it has a data element attached to it, you can decide to style by this data element. So instead of just showing the events as black dots, you can here see that it's styled by the mode of discharge as an example. So you can also try to get patterns out of this. It works for some data elements. For example, the diagnosis, you know, that can be thousands. So trying to style by that element will make a legend far too big. But for most data elements, that should be something you can do. And also another thing with these event maps is that you can often have hundreds, even hundreds, thousands, 100,000 events. So that's why we have, one more here. We have made a data table for most of the layers. So this one is showing for event layer. That was the last layer we supported. So the data table is a table view of the same data you see on the map. It was added in 235 for the event layer. And it's a great thing to, the Maps app is not only to show the data, it can also be a way to drill down and investigate and look for specific cases. So what we see here, you have these filtering capabilities. So here mode of discharge is set to died, and then age is less than 10 years. And then you are left with 2 events only. So you can see as you type here, the maps updates automatically as you type, and you're left with the filter. And then this one is that if you have many events, you can decide to group them into these clusters that are lying close to each other. And you see here too, also we are keeping the styling. So we call these donuts, but the outer circle is showing the representation of the events inside of that bubble. And then in the last couple of releases, we have worked on a lot on catchment areas. So as you know, catchment areas are the area where the hospital is getting their patients from, or where the school is getting their pupils from. And often that could be good to define to have, for example, an approximation, to know the number of population, for example, living within this area. So if you have, we don't have any built-in support for creating catchment areas. This is a very complex thing to do, to create these areas. But you can easily import, I will show you different ways, you can easily import these catchment areas into the system. But when you have catchment areas, you will see in these org units, when you select your org units for your layers, you will see you have an extra drop-down called associated geometry, and there you might see catchment areas or other types of areas defined. So the new thing here is that if you have an org unit, it can have multiple geometries attached. So normally a facility will only be a point in the version you're having, but it can now also be a polygon or the area where which is the catchment area for this facility. If you have 238, there is an app I would advise you to check out. It's called the Micro Planning app from Crosscut. It will help you to automatically create these catchment areas. So it will use your facilities and it will also use your districts, and then within the district boundaries, try to define the catchment areas based on factors like travel distance, if there are a big river blocking, mountain ridge, land cover, all these kind of factors. And this can be good as a starting point for your catchment areas. And then later on, you can go in and edit this manually if you see that this is wrong for this area. And then in 239, you can also import from any tool the catchment areas you would like to use. So this one shows two examples with catchment areas. What you can do when you have imported it, whatever you select the facility points, you can now select the catchment area instead. So this one is showing a thematic map where the catchment areas are colorized according to the statistical value. We will later show you how you can calculate the population within the catchment areas. But this one is also, it can be a useful example. We have this detailed imagery from Bing. And especially if you're a bit uncertain, because you know your districts, especially if you're bigger, you can zoom all the way in, you can see the individual neighborhoods and housing, and you can see where the catchment areas are drawn on top. So you can sort of ground truthing, we call it, and see how accurate they are. So here you will see that the catchment area is clearly defined along a road. Then we are moving on to the Earth Engine layers. I know quite a few of you have signed up for Google Earth Engine. Now I really recommend the rest of you to do it. I think I have 20 countries been signing up the last few months. The process, it used to be a complicated process. You had to do the sign up with Google yourself. Now it's super easy. It's easy is to send an email to maps@dhis2.org. You will find the slides and you will find everything information there. But you only need to send an email, ask your system administrator to do it, and we will fix your access. So it's done in a few minutes. And then you will have access to these powerful layers. So what's special with this Google Earth Engine? It's called an engine because it's not only like a repository for data, it's also, they provide all the computing power in the cloud at Google. So you can do a lot of interesting stuff with this data. But they do this, DHIS2 is supported for free, no extra cost. This is for a good project for Google, so you don't need to pay anything. What they are providing is a way for organization to upload their data. So we have data, for example, from these 3 organizations. They add it to Google Earth Engine. And then what we do is that we pass in the organization unit from the instance. And then we use this data to calculate. For example, we would like to calculate the population within the district in your country. And then we get that result and present it. So, and all of this is happening on the fly when you click the add layer. So this is an example of elevation in Sierra Leone. So you can see you have the base map showing the elevation with the color scale. but also we have access to the raw data. So if you right-click anywhere on this map, you will see the elevation at exactly that point. You will also, if you click on this, you will see aggregated values. You will see in this district, the max value is 1933, which is almost the same. This resolution is 30 meters, so it's almost the same as the highest point. And you can also have the min and max. You can decide how you want this data to be aggregated. This could be used for malaria risk mapping, not in Sierra Leone because it's a low altitude country. So there is malaria risk all over the country. It's not connected with altitude. But this is just showing an example because you can set the min and the max. And for example, you can define that the dark color is a high risk area and the orange color is a medium risk, for example. And I did this for an academy we had in Delhi, where there were participants from Bhutan, where malaria is very connected to altitude. So then this is not created in, the data is from DHIS2. I created this map in QGIS in another GIS program, but here the red areas mark the area where there is malaria risk below 1,700 meters. And this is also an example of thing how effective maps can be. You're trying to describe this in words where these areas are. You will, it is hard. And you can here also see easily that there are at least 4 states where basically there is no malaria risk. We also have added a land cover data set, which also might be used in with vector-borne diseases and health. This one is showing, so land cover or land use, it will show how the landscape varies within the districts. And this one is showing a state there where the permanent wetlands is almost 18%. And then again, if we take up the data table, you can click on the titles there, and then you will sort the results. So here you can see these are chiefdoms. You can see the chiefdoms with the most percentage of wetlands. So you can see there is BMC state. No, chiefdom here is having more than 50% of the land area is considered to be wetlands. Then finally, we're moving on to population, which is probably the most interesting and useful. We are using population data from WorldPop. This one shows a map. This is 3 map layers here. You have the population density at the bottom. Then I've added chiefdoms boundaries on top, and then the health facilities. So this might be useful to see if there are areas which is not covered by a health facility, but where there is a high density population. So for example, I just added the circle in the middle there, might be a candidate for where to add another health facility. A little bit behind the scenes, what's special with this WorldPop dataset is that it's very high resolution. It's 100 by 100 meter is the resolution. And within every one cell, 100 by 100 meter cell, there is a population estimate. This slide is from WorldPop. I would advise you to go into WorldPop and see a presentation there for how this is created. But based on a lot of data, satellite imagery, roads, building footprints, land use, they are able to create this model of the number of people living there. It's not necessarily completely accurate within a cell, but within a larger area, these estimates have been proven to be quite accurate. And then, so this is just a small area, and you can see the cells with a number of people living there. And then what makes this so flexible is that we can add every layer on top. And then what we basically do is just to count the number of cells that falls in catchment 1 and 2, and then we get the population estimate. And all of this now is built directly into DHIS2 maps. So the 2 population layers we have is this one with the total population, And then during COVID-19, we understood or got feedback that it's crucial to have the different age groups. So for example, to find the elder population. So then we also added the population age groups layers, which is divided into a gender and sex structures. So here you can see that you can select, for example, male and female under 5 years, or if that is what you're interested in. Just mentioning here, WorldPop has many different data sets. We have added 2 that are globally available. They are based on a top-down approach, which means that it's taking your census data as a starting point. So when you add up the number for the year of the census, it should match the numbers. And then there are projections from that census into the future. I also know that the population data can be very disputed. This is nothing we import to the system. This is only for you to view. It's not taking over the population data you already have in a DHIS2 instance. This is only on the fly measurements in the Maps app. Also, the data we have is for 2020. Now we get a lot of requests because they want the data for this year. The good news is that WorldPop is currently taking even more newer census data where they have been in the recent years, and they will now produce these population numbers for 2020 until 2030 with projections. So what you can do with this data then is that you can try with your own districts, select the population layer, and you will instantly get an estimate of the population within. So you can see in this Gaura, you will see 24,000 in estimated population. And you can also, like I said, previously use the data table much more. You can sort by them by the value and have it presented like this. And then again, this is the age groups. You see, you can both see the individual age groups and also the total for the group selected. If you don't have catchment areas defined, you can select a buffer. So if you would like to see the population living within 3,000 meters, for example, from a health facility, you can use this feature. So you will see here 3,470 lives 3,000 meters within 3,000 meters from this facility. If you have catchment areas, this can be defined much more accurate. So here we have the same district with a catchment area, and you will see that the population is then much higher, more than 9,000. Another thing we have added, this is in 237, is that the Maps app is probably the best app to use to have a good overview of your facilities. And there has also been a lot of discussion on the master facility list. So you are collecting a lot of data about these facilities. And what we have made is something called the org unit profile. So whenever you have a facility on your map, you click on it, you will have this view profile button. And then you will see all the information you have about the health facility. This can be configured, so you can decide what you would like to see. You can even add an image to the health facility. You can see the name, contact person, and you can also select what kind of statistics you would like to see for each health facility. So please use this one more. My last slide is that we try to cover many use cases with DHIS2 maps, but we will never be able to compete with a proper GIS system. And also, I don't think you want us to be a proper GIS system as well, because these are very complex to use. So we want the most common task, especially if you're looking at your own data. DHIS2 maps should be the app you should use to make a map. But if you would like to combine your data with other data, we might in the future add more possibilities to bring on other data sources, but very often you will need to go into another program. And we also had academies, and so we see that people are learning quite fast the other programs, and then we have made it very easy to get data out of DHIS2 into another program. So you have if you click on that menu when you have your layer, there is a download data button. An important thing here is that when you download the data for a map, for example, you're not only getting the org unit or the facilities, you're also getting the data attached that you see on the map. We see that some people use a complicated process of going into matching data, linking the statistical value to the org units. If you use the Maps app, you don't need to do it because it's already attached. So just download the data and style it again in QGIS. So this is just an example. Download the facilities. Then we have settlement extents from grid 3. So this is showing where there are settlements. And then we are combining these two in QGIS. And here also you could see if there are areas that are not covered by a health facility. So for example, on this map, I saw this seems to be a larger settlement there to the right where there is no facility. That was my last slide. So we'll move on how we can build capacity on using maps. Thanks.
Good morning, everyone. So you've heard that making maps in DHIS2 is easy. You've also gotten to see a lot of the really fantastic features within the Maps app. And you've also seen that there's a lot of really powerful data that's made available to DHIS2 users through a tool like Google Earth Engine, so population data and earth science data, which coupled with the routine information that you have in your DHIS2 instances can make very powerful maps. You also heard, though, that the Maps app is one of the analytics tools that's the most relatively least used within the DHIS2 platform. So we wanted to learn more about what are the reasons behind the limited usage by gathering insights from the field. So we started a collaboration about a year and a half ago, including UNICEF, Grid 3, the HISP Center, HISP South Africa, and Ministries of Health, and HISPs in 5 countries in East and Southern Africa: Kenya, Uganda, Rwanda, Mozambique, and Zambia. And again, the idea was to understand why the app is relatively limited in use, and also what are some of the current practices in the field, and how can this be supported better within the existing functionality. The results today reflect the inputs of many individuals, some captured in the slide pictures, some in the room today, and some that are joining remotely. And so we hope you'll be inspired by some of what you see today as a result of what you can do with some capacity strengthening and leveraging some of the functionality within DHIS2. And then you'll be part of the community that we're building here to strengthen map use. So again, a strong motivation behind this collaboration. Bjorn shared some of the data that's made available, for example, through WorldPop, innovative data that's very granular and can be aggregated to different units of analysis. And we see that there's a strong demand to represent data spatially. And again, we heard from Scott that this does require special skills around how to represent data spatially and how to use and interpret that data. But again, we understand that there's limited use of this information. So we wanted to get insights from the field and identify what are those opportunities to strengthen map usage. So we convened in Nairobi last November, and we brought together Ministry of Health from Kenya and Uganda, including program staff and HMIS staff. We brought together DHIS2 developers, and we brought together population modelers, along with HISPs that support implementation in these countries. And we used a range of different modalities to facilitate dialogue. The dialogue and discussion was really important. Again, to find out what are some of the current practices in the field, what are some opportunities to improve, and where users were having some challenges or constraints in using the DHIS2 platform, Maps app. So what did we learn? As you heard earlier today, we know that facilities in terms of using data and also in districts like to have map printouts. And we found out that the functionality in DHIS2 in terms of downloading and printing maps had opportunities for improvement, specifically around some of the labeling, the download options, and the layout. And so as you heard today, in the latest release of DHIS2, this was one of the features that was prioritized. That was a direct result of some of the consultations that happened. Again, having the diverse group of people, the ministries, implementation support teams, and also with the exchange of population modeling team and others. We also found out that the process for signing up for Google Earth Engine was very cumbersome. And so again, while many users may have known that these features existed, just as you learned today, there were challenges in setting up the access, the sign up for Google Earth Engine and DHIS2 in the national instances. So again, this became apparent from the dialogue that took place. And now the process is simplified. And since November, there have been 18 countries that have now enabled this feature in the national DHIS2 instances. You also heard earlier today about the need for capacity strengthening around map making, interpretation, and use. We learned from the field that users would like to have more skills development in this area, and also that they were not always clear what are the possibilities of representing data spatially and how this might differ from analytics and charts. We also learned that users wanted to have ongoing capacity strengthening given turnover of staff, and also the need to scale and sustain. This isn't a one-off thing. So one of the things that we did working with HIS South Africa was to develop an online Moodle course that can also be further adapted for national, if you happen to use Moodle in your countries, that provides some principles around GIS and introduction around how to use the Maps app. We also developed a Level 2 Maps Academy, and Sylvia will be sharing more in a little bit around what's possible in terms of in a short amount of time, some fantastic maps that I hope you all will be inspired by. We also learned that there's a challenge of data. So data availability, particularly population data at the lowest levels of the system, and issues with missing facility coordinates, and also with misplaced coordinates and having updated shape files or administrative boundaries to represent changes over time and, for example, district formation. So all these things are realities that will come up when, for example, making maps. But one of the important lessons that emerged is that by highlighting these issues, by using the data, it's created greater demand in terms of improving the geodata in DHIS2, and also a greater demand for using some of the innovative population and earth science data that we have been sharing. So with that, I'm going to turn over to my colleague Sylvia, who's going to be sharing more about the Maps Academy.
Thanks, Maria, and good morning, everyone. My name is Sylvia Wren. I'm a GIS consultant with UNICEF and Grid 3. So if you have any GIS related questions around data or GIS, come see me. I'm around. So I just wanted to give you a quick overview of the Level 2 Maps Academy that we did in Cape Town, which was maybe a little bit different than some of the other academies that have been held. So first of all, we spent a lot of time trying to make sure we get the right mix of people to attend. And this was not just the technical teams. We really wanted some program staff and decision makers within the programs there as well. And we wanted them to come from the same country. So if a country was present, it would be both the technical and the data use teams that were invited and that came to this Level 2 MAPS Academy. We had some pre-course requirements. One of them was that they needed to have done a Level 1 Academy and that they took a Moodle, which was an online MAPS course, so that they already had some foundations before they came in to this academy. We did also make sure that the use cases were based on use cases that they were using or needing in country within the next few months. So the maps that they produced, and I'll show some examples in the later slides, were some that they would be using back home. We also used the country databases. So we didn't use Sierra Leone or Laos. We used all the country teams were able to use their own instances. We had some really fun activities. So we also tried out the tracker where we mapped ice cream shops within Cape Town. And this was mainly because a lot of people, they see these raster layers with population in them, and they don't really know what to do with that. So we had people go out and estimate populations around ice cream shops. We also have supported with the online learning. So that was the Moodle I mentioned, and we will be following up with participants as well. If you're more interested in this Level 2 MAPS Academy and some of the things we did, then Nora will be talking about this in a lot more detail in tomorrow's session.
Sorry, everyone, we're having some internet instability, and if you're not, you don't have something essential you have to do with your computers, we'd appreciate it if you not do anything that's high bandwidth, because we're trying to make sure we keep the stream going, which is crashing at the moment. So we'd appreciate it if you just shut down any high bandwidth activity. That would be great. Thank you.
Okay, thanks. So I just wanted to show a few maps that were made by the participants. And please keep in mind that while some of them have done the Level 1 MAPS Academy, these are not GIS experts. So these are people that are using mostly the DHIS2 MAPS app with some of their data, and based on discussions that they had with their program staff that were also within this MAPS Academy. So this is a map of Uganda that shows the women of childbearing age and the ANC4 coverage. And here you will see the black is and the gray is the women of childbearing age per hectare. And maybe just to add to that, this is really powerful because it shows you the location of populations. Whether it's 6 or 10 women there it's not that accurate. Especially a lot of this is 2020 data. It's kind of a top-down approach, which you can look at more on the World Pop website. But for the first time, I think some of the DHIS2 users can actually see where people are in their catchment or in their districts. They've put facility distribution on there as well. And then they can kind of see the ANC coverage. They've also then made a map to look at the number of deliveries and saw that a lot of, while we do have women who are doing ANC visits, there's a good possibility that they're traveling quite far up to the north there to actually have the babies. This is an example of Lesotho. This one actually won the MAPS competition. And here you can also see some of the level of detail that these maps can give you. We're getting a lot of requests from countries to do geo-enabled microplanning. So to kind of get catchment area maps that do have a lot of detail. And here you can see a lot of detail in the yellow, the yellow boundaries. I think I'm hoping you can see them. Those are the catchment areas that were generated by the Crosscut app. And then they also showed the home deliveries by using the bubble map there. So you can see St. Joseph's catchment has a high number of home deliveries. And then they used the new ANC clients data as well to show how many new clients are there actually within that catchment area that's showing a lot of home deliveries. And then they also use the how many of them are under 20 years of age, because there's a high maternal mortality in that district in general. Here's another example of the map where they used the Penta 1 data together with population, and they used 2 kilometer buffers to look at where our population that are over 10 kilometers away from our health facility. And again, these are basically map newbies, being able to do this in the DHIS2. Here we have an example from Zambia, where they're just kind of drilling down to say, well, Northern Province actually looks pretty good. It's in the green. But when we then look at the districts of the Northern Province, we can see that there is at least one district who's underperforming in the coverage. Here in Tanzania, we have an example of MR1 coverage, where we can also see, where there's increased coverage in the blue, and then low coverage in the areas around where we have increased coverage, which may be an indicator that the people from those areas are going into, for example, Kibiti to get their vaccines. We had an interesting example from South Africa, where they were exploring the population data and in an area which they thought they knew fairly well. And you can see this is a very remote area. You don't see roads or anything. And they actually did find populations in that area that they said when they went home, they're going to need to explore that because they'd never actually gone out there. This is an example of the population data in an urban area, also an example from South Africa, where they were looking at the TB rates, and they looked at the population under 5 years of age and just kind of looked at that together in the urban area. We've already had a follow-up from Zambia. They wrote into the community of practice, I think, which is great, that they have been showing the districts how to use the Maps app to understand performance within their districts. So here we can see them in the district office, and one of the people that attended the Maps Academy just kind of passing on that knowledge and using the Maps app. What's next? Come to the session by Nora tomorrow afternoon, and we can discuss this further. Please also join the MAPS community of practice on the DHIS2 community. Here you can upload your maps, or if you have questions on making maps, it doesn't just have to be on DHIS2, it can be in QGIS as well. If it's kind of routine data related, then please do join that. There is also a really great Maps app Moodle course developed by DHIS2 South Africa, which you can sign up to and do in 1 or 2 hours, and it will really show you the features that are available. If you would like to sign up to that, you'll get a certificate. Please contact Nora. Nora, I think most people know you, but maybe you can wave or stand up really quickly. Please contact Nora, and she'll make sure that she can get you signed up. There's more to come, so we'll have some more e-learning, Moodles, videos, and jobs aids. And since the health facility locations are so important to a lot of the maps that we see that are being made and requested, there'll also be a health facility coordinate checker that's coming. That's it from me. Thank you.
Okay, so that's all the presentation we had. Just one thing I wanted to emphasize about the last presentation was a lot of times people ask us, how do we come up with the features that we put into DHIS2? Sometimes it's very opaque process. This is not the Willy Wonka chocolate factory where we just kind of dream up our own movie book reference that maybe not everybody gets. But anyways, the point is that I hope you noticed from the presentation how we actually tried to convene a workshop to understand where the barriers were and to then immediately bring those barriers back into new functionality. And that's kind of what we try to do for all of the apps and everything we develop in DHIS2. We don't just dream it up. There has to be a real need. There has to be an actual implementation. And we don't actually even have the resources there to do like cool, fun things that we think would just be interesting. There has to be a use case. There has to be someone specifically asking for it. I need this functionality because I need to use DHIS2 in this way. So, if you're, hopefully that gives you a little bit of insight. And if you'd like to be more involved, engaged in the development of the Maps app and giving us requirements, we're the folks to talk to. We can bring you into the community practice where we have a continuous dialogue about the latest functionality and things that you think need to be there and what other folks are using the Maps app for. And so we're very happy to invite anyone and everyone here to join that community. And if you go on to the community practice, community.dhis2.org, there is under the implementation thread a link just for the Maps community. So please join that, and we'll keep the conversation going. Now, somehow, by the grace of God, we've ended early, and I think that gives us a very unique opportunity to have questions. So. Yeah, sorry, we should have warned you, Max. Max. So we covered the new functionality, we covered capacity building, and we covered some examples. Does anyone have any questions? Raise your hand. Someone's got to break the ice. Yeah, oh, sorry, Joseph has right here.
All right.
Yeah. You're probably going to reference a bug that we haven't fixed yet or something.
Yeah, thank you, Joseph from Malawi. Yeah, it's a great new development, but with regards to the GIS, I think the key thing is about the whole data source and how we are going to manage the shapefile and all the metadata. So I don't know, do we have somewhere that like a global repository where we can easily access all sort of like population and even with the climate, weather data, and then that we can further use it. And also like from the country's perspective, like we also generate the local maps and the local data, like the health facility, we have our master health facility registry. So how we can sort of like creating the synergy, not only within the country, but maybe within the region and also the continent and even worldwide, so that people can benefit out of this. Thank you.
So yeah, it's a tricky question. There are various resources to finding good data. Speak up. So there is a site called GADM, G-A-D-M, which have boundaries. I would also advise you to come to we'll be more specific about resources. We will be more specific about resources when we have the meeting tomorrow, to finding this shapes file, for example. I can also say you that this process of getting new boundary data into DHIS2 has been quite complex. If you have ever dealt with it, in 239 it's much easier. So we have improved that workflow. So I see some happy faces here.
Thanks. Maybe if I can add to that as well. So there are various global repositories. GeoBoundaries is a really good one. It has GADM data in it, but here you can compare boundaries from different resources and at different administrative levels. So you can compare them directly to see which ones match your country best. We have the Grid3 website, which has settlement extents for all countries. You have hot OSM for health facilities. What I can do on the Maps community of practice, I can maybe add some of the global repositories that we would recommend for you to have a look at. Please do remember that if they are global repositories, they may not match the national data that you might get from your health facility master list or from your Ministry of Lands in terms of boundaries. So that's just something to keep in mind when using the global data sets. But there is a lot available. Yeah.
Just to add one thing is that as part of this collaboration, we have been working with a number of different countries to create what we call bespoke modeled population data sets. And there are also other layers of interest, for example, like the roads that are not available in Google Earth Engine, you may have your local data. So I do think that that is still something that we need to sort out, is how we can make available in some kind of repository some of this data so that you can use the data from that you would prefer from your countries, for example, if you want different data than the one made globally consistently available through World POP. So again, something that we would like to explore in the near future, working with DHIS2 team and others.
And this is also something we will cover in the session tomorrow. So it's at 2 o'clock. It's in the technical track. Don't be afraid that it's too technical. It's basically more how to learn about maps than actually learning the complex GIS and tools. So don't be frightened for joining.
All right, thank you. My name is Lawrence Flank Nyambalo from Malawi. I'm from the expanded program immunization. I was equally interested when I heard about microplanning. And I just want to compliment on what my colleague has actually said again on the same. So in immunization, we are so much interested in access and utilization. So I was also considering to say on the geospatial tracking system, where much we are using again geospatial microplanning, to say, don't you see that also as a need to say, maybe if we might also bring in a system, the GTS, where you'd be able to actually track, to look at maybe the vaccinators as they're trying to reach out to the children. Maybe you've already done your microplanning and then you need to find out to say, will the vaccinator be able to track each and every child, so that we really work again on the utilization and of course accessibility. So I don't know, on your microplanning, geospatial microplanning, how do you plan to get to those levels where you have to also consider the geospatial data? I don't know, don't you see that as a need in the near future? Over, thank you.
Yeah, it's a good question. Thank you for that. I'm not sure how far the tracker app can be used, like the GTS. I know the GTS has a dashboard that can be used and that shows you how to track. And it uses some of, like, I think it uses the settlement extents as well to show you where you've been and areas you've covered. You can obviously use that data and bring it into QGIS, and then take data from the DHIS2 and then also add that to QGIS. So that is possible now. In terms of linking the GTS with DHIS2, maybe that's something to ask for.
No, it's good feedback, and we have been looking more into aggregate data than to individual based data so far. I think there is a tracked entity layer also in MapsApp, but it should be really get some more love and focus. So there are possibilities and people are using it. And you have the app where you can capture coordinates, even multiple coordinates for some like contact tracing and so on, but it's still limited. So I think often still you depend on moving into another system to do this analysis. Would you like to add something?
Yeah, just to point out that planning and micro planning is one of our be careful with your toes, everybody. Sorry, Kristen. I think there's quite a few doctors in the room if we need any. Okay. So what I was going to say was that microplanning is a key use case for us. It's specifically, we are really analyzing the functionalities that are required to be able to conduct micro planning all the way down to health facility, community level in countries, and making sure that DHIS2 has all of the necessary functionality. It's a process, and there's different ways. There are different types of micro planning. So you have different plans for like immunization. You may also have different kinds of micro planning approaches for other types of outreach services like insecticide net distribution or maternal follow-up, et cetera. But we are part of a global community that's analyzing digital tools for micro planning. And if your country is going to do any micro planning and considering to using DHIS2 for it, please talk to us, tell us what you need, what you have, what you don't have, and then we can kind of go through the process together. But it is a key use case that we're aiming to cover. I do want to mention two examples that we had presented earlier. This one's from Uganda, and if you remember, and Uganda is actually able to use this map to inform microplanning. They have microplanning coming up, and they have used DHIS2 for microplanning in the past. I think some of the Ugandans in the room could probably, Prosper certainly could elaborate more on that. But the point is that with these maps, you're able to see where people live, right? And you can see that quite quickly. This is quite zoomed out, but if you can zoom in and you can see where the actual structures and buildings are, where people live. And obviously that's a critically important part. You can also see where the health facilities are. And so you can very easily, just like they did in which one was it? Ethiopia here, you can see all of those populations that are quite far away from health facilities, 10 kilometers. And we know that that is a barrier to access, that distance. With these maps, I mean, it makes it as obvious as you could possibly get it, certainly. The other one here that was from Lesotho is also extremely interesting because you can see the health facilities. Those are the big dots, right? And you can see the catchments, and you can see that some of these catchments are gigantic. And when they were presenting it, they told us, we didn't even know people lived here. It's so rural, it's so remote. And now we know we have to go do campaign planning, or we have to do outreach to those places because there's clearly people there. And it wasn't something that they had an insight into until they built those layers on top of each other. Started with the base layer, added the building footprints, added the population, and then it's clear that that it's there. Okay, yeah, maybe we can. Oh, okay. So now we've managed to fill up the time, but we live here, so come find us. And we have a session tomorrow as well. Okay, so the break. I think the break's at 10. Oh, sorry. No, you still have to sit here. Well, we can answer some questions off of Zoom. So there was breaks at 10, miscommunication. There's a question here in the middle. Okay. Well, maybe, and then we can come back to Malawi.
Right, sorry, everyone. Here, then we'll come back to you. Sure.
Oh, sorry. So I find it interesting. Otherwise, I just want to compliment Arito on what I actually said. So I was looking at a problem at hand here, because you'd see if you get into DHIS2, generally in terms of coverage, it's a problem, because each time maybe, like I would cite our scenario, that maybe we want to come up with a campaign. So there are times we want to get the data. That's when we are coming up with the micro planning, we have to get data from the districts. In this case, we want them to provide us with the national statistical figures and the head count, right? Now, with the geospatial microplanning, in my thinking, I was thinking that if DHIS2 would be able to provide us with this approach, it means issues to do with coverage will not be a problem, because in this case, we'll not have all these headaches that come in when we are trying to reconcile the figures. There are times people would say, no, maybe we want to use the NSO figures, the National Statistical Office figures, and the headcount figures. So these do not actually reconcile. And then you'll see that we want to calculate the coverages. Now that even us, as we are working on the coverages is actually tough, because at times we need to sit down and say, okay, can we work on the proportions and then come up with these coverages? And you'd see that some districts do not even manage to reach out to those coverages, because DHIS2 on its own doesn't provide coverages. We have to calculate separately, work on the population, the proportions, and then be able to give feedback. So I was of the concern of the missed opportunity for vaccination when it comes to children, that most of the children are actually missed. It's either we underpopulate or we overpopulate. And then these proportions are not always realistic. They're worked on assumptions. Would say, okay, if we are to assign to district by district, how do we ensure that we are really giving real figures? So I was thinking that maybe if we may adopt the geospatial microplanning, it's going to be easy. We'll not have issues to do with coverages, because we'll be able to actually track the children that are really supposed to be tracked according to the populations that we're able actually to generate. So I was thinking that if we might come in with the idea of geospatial analysis, in this case, it's going to be easy because it will be direct. It will not be this two-way where the office has to ask for data. That's the population figures, these two, the national statistical figures, and at the same time, the headcount figures. So to populate these, maybe to reconcile, is always an issue. So I was thinking that maybe if we can have that system in DHIS2, it's going to be easy. And the GTS thing, we hope us to actually reach out to the gap that we still feel it's always there over time, because we don't have those realistic figures. We work on assumptions over time, and we really don't speak what happens really on the ground over. So I thought maybe we can still talk a little on the same. Thank you.
It's a really good point. And the sad reality is that I've never worked in a country that wasn't struggling with their population and most countries are struggling with this. And I think the important thing to appreciate is with the maps, you can see where people live. Now, this world pop data is a projection. It's not a head count, right? It's a model. So it's not necessarily exactly what you see. It's also from 2020. And as Bjorn pointed out, they are updating it and even providing some new projections, but it is not your national statistics necessarily. But it is a really good place to start. And it makes it very easy now to use it in the Maps app. But we have actually done a series of webinars on different approaches and methodologies to it's available on our YouTube channel, but I'm happy to share you some links. But there are, and certainly some of the WHO colleagues here have a lot of experience in this as well. So if you're struggling with coverage indicators, just know that everybody else in the room probably is too. And then there are different methodologies to use to calculate them. And then of course the Maps app can be when you put it on the building footprints layer, it's kind of hard to argue with it because it's just, you see where all the buildings are. It's very, very clear. So it makes it quite easy. Yes.
Yeah, maybe also just to add on, I think one of the things that we're seeing a lot of is how important the actual boundary of the catchment area is when you're trying to reach people. A lot of times the facilities have hand-drawn maps. So, and when we ask them to digitize that, we see a lot of gaps and overlaps in what the facility perceives is their catchment area. So when they say, this is my facility head count or my catchment area, they may be under or overestimating what is in their catchment boundary, just because it's never been properly mapped. So starting with just properly mapping the catchment area, and you can use a tool like Crosscut to get kind of a first iteration of that, and then sit with the facilities to make sure they are happy with that. That can go a long way. And then you can use your census population to see maybe it does actually add up. It's just that the boundary was wrong. Or you can sit with your facility and then go through that again, use settlement extents that you can write populations to, and then look at that, look at the population again. But the actual boundaries around your catchment area are really, really important to make sure you get the right population. And that's often an issue that we've seen. Maybe just to add, in some countries, we've done extensive microplanet maps where we've put 3 different populations. We've put the one from the statistics office, a bottom-up model, which uses a more detailed data, like from a census cartography, and the facility headcount data. And then the facilities could choose what they felt was the most accurate. So countries are requesting that as well.
Hi, my name's Lily Symes. I work on the PMI VectorLink project. And on our project, we collect quite a lot of entomology data. And there's a lot of interest in being able to map our entomology indicators like vector density and vector composition along with climate data. And mostly that is, looking at monthly changes to climate data at the district level with our entomology indicators. So far, we've noticed that the climate layers, we're seeing a lot of data at the weekly level, and there are differences in what that time period is based on the source of the climate data that's coming through. So we're just wondering if there's any possible or expected functionality of kind of aggregating climate data at different time periods or flexibility in those time periods that are available within maps.
So, sorry, I need help on this one. The answer is yes, it's something that we're looking very much into, having more granular climate data, but maybe Kristen should.
Yeah, so we have an own session on climate health tomorrow, actually. So please join that one. We have several initiatives around in the countries. And there is a growing demand for combining climate data with health data to be able to predict, prevent, understand the impact of climate on health issues. We are in the process, we could say that, I think it's not a secret. We are in the process of, we actually just handed in a proposal for Wellcome Trust on a big project, 8 years project, with 12 PhD students involving many countries on investigating the impact that the climate health has on health data. So we hope we will start a big initiative, but we don't know yet. It will be decided during summer, so cross all the fingers. But we really believe anyway, even though we're not getting those funds, we believe that that's a growing demand, and it's very important to address issues when it comes to weather data, climate data, meteorological data for the first impact on, and we know already we have done it on malaria, dengue, and nutrition. So we know already there's evidence, but we will encourage people in countries to take contact with climate communities at the universities, at meteorological stations, to start the discussion to see how can we combine data from various sectors in order to solve or to at least address societal challenges such as climate health. So this is a kind of a call for action, and we will have some examples in the plenary on Thursday when we are talking about cross-sector monitoring. So there will be examples, and we actually have a session at 3 o'clock today, monitoring progress across sectors in Auditorium 1, where we actually look at the SDGs to see how we can combine data analytics across sectors. And many of these indicators are climate relevant indicators. So yes, this is very much an up and coming topic for us all.
Maybe I could just add one thing about that specific question. I worked fairly extensively on a proposal on climate health, and the issue of granularity and matching geographical scale comes up in every climate health use case. And the way to address that is by creating customized climate services per use case, which we're planning to work with a few new partners in the climate sciences domain to do. So that will probably be a combination of local climate data where available, globally modeled climate data, but designed to match a given health use case. So we have discussed that with a few different climate partners that we're hoping to join us in the Welcome project. And once those become available, to the extent that those can be made generic and made available for different countries and different contexts, that's obviously the goal, as with any DHIS2 product. But if you're interested, I definitely recommend getting in touch with us, because the first step of that, if we do receive the approval for our project proposal, will be selecting countries and use cases to work with in trying to move forward and develop some viable systems.
And just to add, if there are any knowledge about where ministries are sharing data, we are very interested to kind of leverage upon that, to see what can we do in order to show, or as I usually say, create hope, show examples where we actually can do see the benefit from matching data from local weather data with local health data. Because on satellites, that has been available for quite a while. But it's the same as with maps. The lower you go in your, in the locality, the more relevant they are. So we need to think about that in when it comes to climate as well. Björn.
I would also advise you to have a look at the Google Earth engine. Just Google it and see the data repository. It's a vast resource, and that's climate change is a big issue for them as well, and they are constantly adding new data layers. So, but it's if someone you could have a look if you're working within the field and see if there are more data sets that we could also add to the DHIS2 instance to the Maps app. So please have a look and give us feedback.
Okay, I think we have time for one more question before the break. This side of the room seems to be a bit more tired than this side of the room. Are there any questions over here? Yeah, of course, George always. Yeah.
Thank you very much. So I have one comment and one question. So the org unit profile is really spectacular. I've come across it recently. The other thing that has impressed me, what from Björn said, is that I realized that you could have like the data table at the bottom of the map, but you were just clicking around with the filters, and I realized that you could actually use it for real-time analysis. And that's really interesting, because now I realize that instead of having to create 5, 6, 7 different maps, like, all the zeros or all the ones, you can actually just have one map and give an explanation to dynamically use it, like on the fly. That's great. And the stupid question is, how do I edit the org unit profile?
Currently, because this is a one-time job, we have not prioritized to make this into a nice user interface. So there is an API you need to set. It's fairly well described, sending a request to this API, and it's done as a one-time job, and it will keep and it will be there. So this one basically selects which sort of elements and like metadata attributes or unit groups, what kind of indicators and data elements you want to see. But I see I will take a second round of getting a user interface for this as well.
You have to. Yeah. Pointing at an API link is a bit tough. Okay. We're still just a few more minutes away from tea. Any other questions? Last question. No. Silence is acceptance. Okay.
One thing I just want, because this been a great process this last half year, having a workshop in Nairobi and then leading up to the academy, at the same time working on the Maps app, trying to improve features. So I just want to especially thank Sylvia and Maria from UNICEF, and also Nora from DHIS2 South Africa for organizing the academy, which was a lot of work. It's super useful also for us as developers, and also people sitting in Oslo, come out in the field, learn about the use cases, see how this is used. We were the 14 different HISP groups represented on this, and it is super useful. And sometimes someone from the outside needs to come and bring us together. So I'm very thankful that you did this job. I hope we will continue this great cooperation for the future as well. Thank you.
All right, so thanks everyone. I think we'll go to our coffee break and
Okay, welcome everybody. We will get started now with the next plenary session. My name is Anna Thorseng. I work at the implementation team here at the HISP Center.
My name is Ola Titlestad. I'm also at the implementation group here at the HISP Center, University of Oslo. Welcome to this session.
Welcome everybody. So I'm very excited about this session. We have a good panel here on stage with representatives from governments and WHO office from different countries. These are countries, many of them have been doing DHIS2 for many years, and we think we have a lot to learn from all of you. So next slide. Is that not working? Oops. So up here on stage, we have Brana from Mozambique, head of HIS in Ministry of Health Mozambique. We have Macha from Tanzania over here, Assistant Director, Ministry of Health. We have Masood Ahmed, Deputy Director of Strategic Affairs from Ministry of Health from Ethiopia. We have some little bit newer countries. We have from Angola, Pedro Duarte Gabriel, Head of Planning and Statistics at Ministry of Health Angola. And we have Amer Bebani, Health System Officer from WHO Country Office in Iraq. So all of them represent countries that are on various stages of how long they have been doing DHIS2, ranging from Mozambique for over 20 years soon to Iraq starting this year or last year. So we hope it will be an interesting discussion. We will open for questions at the end of the session from the audience, but first we will hear a little bit from the countries on what they think have been important to sustain DHIS2 up to now.
Should we introduce our friend Emilio?
Oh, I forgot Emilio, sorry. So Emilio Mosse here is from, he's the head of research at DHIS2, his group that is supporting the Portuguese-speaking countries. You're a former PhD student, also from University of Oslo, and he will help a little bit with the translation from Angola. Okay, thank you. Good points. I will leave the floor to you.
Should we
Yeah.
do the next slide? Yeah, so let's start with Mozambique. So Brana, we can see on the slide here that Mozambique has been using DHIS at national scale for almost 10 years now. And I also remember that you started, I think, in 2001 with the early version of DHIS. So it's been many, many years. And we can see that the scope of the system is quite advanced with many health programs, integrations with many key systems. Can you share some insights into the governance and coordination processes that are needed to implement and sustain DHIS at this level over so many years? Thank you.
Okay. Hello. DHIS2 is now since 2015, has been the official platform for data management. We still have some challenge because we have a lot of systems parallel, but we are trying to more and more bring that data and integrate with our system. So I think the key issue with Mozambique experience to sustain over 10 years the DHIS2 is to have a clear national policy. So we try to make the DHIS2 the official platform, and all the partners must be aligned with this vision. And we also reinforce the ownership of DHIS2 in the provincial and district and health facilities level. So there is already, can I say, movement about the use of DHIS2. Of course, we still have challenge to overcome. It's a implementation of a system in more than 1,008, almost 800 health facilities. So we have the same issues as many of the African countries, like infrastructure, communications, the staff that we need skilled in the informatics and so on. But we're trying to build this with the help of our partners, the University of Oslo, the University of Edouard Mondlane. So it's a common effort to really make it happen.
Thank you. We'll hear more from Mozambique later. So Macha, Tanzania has recently celebrated 10 years of DHIS, so congratulations. What are the key lessons learned that you can share with other countries in terms of building country ownership and sustaining a system over so many years? Thank you.
Thank you very much. As also my colleague have already mentioned, also in Tanzania, we strengthen the governance component of the DHIS2, and we take that platform as the government platform for data collection. But also in Tanzania, we decided to use the local institutions, like local university, like University of Dar es Salaam, and also we use Oslo, group, HISP group in sustaining the platform. But during the rollout of the DHIS2, we invest a lot in training at all levels, because in Tanzania, we have almost 11,000 facilities. So we involve all employees at the facilities during the rollout. So by doing that, it make DHIS2 to be a platform which have been owned by all implementers, all service providers at the facility level. But on top of that, we developed the roadmap roadmap of implementing that DHIS2 platform. So doing all that help us to the ownership of that platform. And right now we have already started to be used by other sectors like agriculture sector, and other sectors are interested in using that platform.
Thank you. So over to Ethiopia. Masood, it's impressive to see how Ethiopia has managed to scale up the DHIS2 implementation across all facilities in such a big country. Can you share with us some insights into the structures and processes that need to be in place in order to manage such a challenging implementation in low resource setting? Thank you.
Thank you so much. So when I talk about our DHIS2 implementation, I'm talking about the country, the second populous country in Africa, next to Nigeria, having more than 4,000 private health facilities, 3,600 health centers, more than like 500 hospitals. And the DHIS2 implementation is started in 2017. The implementation touched the ground within 6 months. So what makes sustainable and the leading factor? There are a lot of issues as a country. The first one is we had a strong HMIS, paper-based system. So that system is the foundation for DHIS2 implementation. When we designed our health management information system, we have designed it in the way that it will be sustainable. So our health management information system, which is designed and implemented in 2008, has 4 principles. The first principle is, standardization. So we have standardized everything: the reporting format, the data elements, the indicators, the numerators, the denominators, when to report, what to report, for whom to report, when to report. Everything is standardized and documented so that everyone will abide to that principle. The second principle is simplification. So we don't have to respond each and every need of the health system through DHIS2. So it's very simple data elements in order to be reported from the grassroots level to the next level. The third principle is integration. So before our health management information system, data were coming from the grassroots to the national level by the program. There was parallel reporting to the national level. TB were reporting directly to the TB unit, malaria to malaria unit, HIV to HIV unit, but we make a kind of decision to make it integration. So we have an integrated system. The fourth principle when we implemented our health management system was institutionalization. The first aim of sending the report is not to send the report for the purpose of sending. So the data used as the point of data collection. They need to use that data as the point of data collection for sending to the next level. So these are the four principles. The second one, in terms of having good DHIS2, we invested on human resource. So at the time when we implemented our HMIS, there was no designated responsible person working on health management information system. So we have created a category called HIT, Health Information Technicians. They are mainly responsible for data management, data collection, analysis, interpretation, and sending the report. There are now some capacity of HIT, technology. They have now some capacity with informatics and some capacity with health and some knowledge and skill on biostatics. So we have created this position and we deployed within 5 years so that they will take over. The third one is we do have a special funding mechanism. So since we are living in a resource limited country, we have a funding mechanism called pool fund. So whenever a donor comes to the country, we mobilized different resources, put in one basket, so that the country is responsible in terms of assigning the fund based on our priorities. So that mechanism helps the country to invest a lot to push the DHIS2 implementation forward. The fourth one is the governance system. We prepared manuals, guidelines, structures that can facilitate and support DHIS2 implementation. The fifth one is, we don't allow our system to revise it more frequently because, whatever we revised in our indicators, since they didn't need to include it to our DHIS2, we don't allow to revise it within 2 years, 3 years. A minimum, we were waiting to revise our DHIS2 at least 4 years and 5 years, so that the resource and other things will be minimized and will be more efficient. The sixth one is government ownership and commitment. So, from the day one, the government is very committed to lead it. We are sitting in the driver's seat. Whenever the partners, the donors are coming to the country, they align based on our priorities. We have the principle, 3-1 principle, one plan, one budget, one report principle. So when we have the resource, they are located based on our plan. Whenever they want to have a data, they are taking the data from our system. Whenever they want to, have a plan, they are aligned with that. So with this principle, the government is leading, and the government is, the commitment to invest in some infrastructure. Like we invested a lot on infrastructure, buying computer, having health net, human resource allocation. At the same time, we decided to use DHIS2 beyond the routine RHIS, routine health information system. Currently, the last 3 years, we were using DHIS2 for COVID response. Even we were using it for data entry as the laboratory, because it minimized a lot of resources, because human resources working at different levels knows DHIS2, so that we went to use that capacity in terms of implementation. So this is a government commitment. The other one is collaboration. We wanted to collaborate peoples on these areas. The last one, I can share my experiences. We have to have a strong M&E system, which means we have regular programs to do self-assessment. We let them conduct self-assessment at facility level. we call LQS. There is a system to conduct from the district to the facility RDK every quarter. There is a supervision. There is a performance monitoring mechanisms. There is annual conference. There is JSC regional health bureaus with the ministry. So we established a kind of strong M&D system for the DHIS2 platform. These are some of my experience I want to share to the committee. Thank you.
Thank you so much.
Thank you so much. Yeah, sorry. Okay, so now we are moving to the countries who are a bit fresher in the DHIS2 world. I think maybe I will start with Angola, if that's okay, going by a number of years with DHIS2. So Angola, you have been doing DHIS2 since 2016, and then 2019 you went full scale. So I understand you are working mainly with aggregate data, but you have a priority to move to individual level data soon. Do you want to talk a little bit about your journey and your goals for the future and what you can learn from these other people? Okay.
Thank you, Anna. Hello, everyone. My name is Pedro Duarte. Angola teve o seu início, ou os primeiros passos relativamente ao DHIS2, como foi já que bem dito, em 2016. E a partir do janeiro de 2019, nós adotamos o DHIS2 como sistema de informação em saúde.
So, sorry, Angola started the first steps in implementation of DHIS2 in 2016, but in 2019 it was kind of official kind of roll up in some other districts.
A gestão do sistema de informação de saúde em Angola é feito pelo Gabinete de Estudos, Planeamento e Estatística, e tem também o suporte, ou trabalha de forma conjunta com o Gabinete de Tecnologias de Informação e Comunicação, o GTCI, que é responsável pelo suporte técnico a nível da plataforma.
The implementation of health information systems at the Ministry of Health in Angola, there are two institutions. One is for management, and another one is the one that deals with the technical part. So GTI stands for Cabinet of Technology, for Information Technology, that is providing the technical support, and GP that is deal with the management of health information systems.
Dizer que durante este período todo, desde a implementação e agora a adoção do DHIS2, Angola conta com o DHIS2 em toda a extensão do território nacional, nos 164 municípios que o país tem. Todos os municípios já usam o DHIS2.
So the DHIS is rolled in all 62 municipalities in Angola. They are using DHIS too.
De facto, tem sido um caminho árduo, mas de muita aprendizagem. E fruto disto, nós já temos quase todos os programas da saúde pública, que também faz parte da equipa técnica do DHIS2, juntamente com o GEPO e o GTCI, os programas de saúde pública. Nós temos dados agregados para vários programas, como, por exemplo, da malária, da tuberculose, o VIH, o programa do PAV, e passos estão a ser dados para melhorar. Nós temos ainda esta informação de forma agregada.
So it's been a long way, this implementation. But the good thing is that all programs, they are using aggregate. I mean, DHIS is used for aggregate data. So now we are moving slowly to individual data.
Atualmente, uma das questões que as equipas que trabalham em torno do DHIS2 em Angola tem estado a olhar com alguma atenção é ter o tracker para alguns programas. Falo precisamente, por agora temos aqui a questão da malária, da tuberculose, que já tem as fichas desenhadas, e para o caso específico da malária, já está-se a fazer o piloto em uma província para poder implementar assim o tracker para a malária.
Currently, we are implementing slowly the tracker, but tracker for malaria, for HIV and tuberculosis. Currently, there's a kind of a piloting in malaria in terms of getting this individual data.
Para o caso específico do VIH, o Instituto Nacional de Luta contra a SIDA em Angola, ele já vai fazendo algum exercício de ter os dados individuais usando o aplicativo Event Connector ou Capture para ter aqui os dados individuais do VIH, mas o passo que nós pretendemos é mesmo ter também o tracker para o VIH.
So currently there is an institute of fighting against HIV. So now is using the tracker capture to collect data from individual data from HIV. But what we want is that really to implement the full tracker in order to get this data.
De uma forma resumida são esses aspectos. Dar nota que existem também outros sistemas que, de certa forma, servem de apoio, estão adotados pelo país para suporte ao sistema de informação e que precisamos tê-los conectados com DHIS2. E face a isso, nós temos vários desafios em Angola com vista a implementar ou estar a par ou seguirmos alguns países que nós já ouvimos aqui, né? Como é o caso de Moçambique, que já está a usar há bastante tempo e tem uma vasta experiência, a Tanzânia também, como nós aqui ouvimos, e como bem ouvimos também aqui a Etiópia. E face a isso, nós pretendemos implementar o tracker para os principais programas ou para algumas doenças, como já frisamos aqui, como desafios, a malária, TB, o PAV, VIH. Precisamos também, em função dos vários sistemas, ter a interoperabilidade nos sistemas face ao DHIS2.
So we have other systems that are collecting data for different data in different programs. So what we want now is to integrate all this program to DHIS in order to get data from DHIS. We're still facing different challenges as we had from Mozambique, Tanzania, and Ethiopia, because they have a kind of a long experience in implementing different kind of stage of implementing DHIS. But what we want is to learn how we can also be able to implement the tracker in order to get this individual data.
E também precisamos ainda alargar o agregado das fichas para outros programas que ainda não temos, né? Como desafios, como é o caso do programa da luta antidroga. Nós não temos ainda as fichas, estamos a implementar o agregado para esses programas e alguns. Esses são os principais desafios, assim de forma resumida, que nós temos para Angola. Obrigado.
In summary, we also need to strengthen even the aggregates, because there are still few programs that are not collecting that. We have forms, but they're still not collecting this aggregate data in DHIS, like against the, I mean, it's related with the drug. No, it's against the drug, luta contra a droga, no? Yeah. So there are other programs like this one that is mentioned here, against the drug, that is collecting in paper form. So we need to put it in DHIS. So in summary, is that what we can say from Angola? Thank you.
Thank you so much. Lastly, I will, and not least, hear from Iraq. This is one of the very new DHIS2 countries, started in 2022 and operational now. slowly in 23. So I would love to hear from your experience and what you think you can learn from these countries that have been working with DHIS2 for a long time.
Yes, hello everyone, and thanks Anne for giving us this opportunity. I'm in leading health system activities in Iraq, in WHO Iraq. So, I mean, more or less, Iraq's is situation similar or a little bit different from the other countries. Like for Iraq is a rich resource country, and it makes sometimes more than some other donors, like for example, 10 billion every month from the oil price. The approach that we supported Iraq. I mean, Iraq, just to give you some background, this is not the first attempt for Iraqi Ministry of Health or embarking on digitalization. It started actually in 2015, but it didn't go as it was wished for. So for us in WHO Iraq, it was important to understand the health system main challenges. So we linked the information, the digitalization worked, the team of the information management with the health system worked together to understand what is the main challenges of the health system and how can we generate interest of the decision makers on investing in health information system, on digitalization. Like other countries, Iraq developed its health information system paper-based in 1983. It's very well structured. It captures all the HMIS data, and then there are other few digital or semi-digital programs running, but they are very much fragmented. So the first thing in Iraq, I mean, after 2013, we need to understand that the decision in Iraq is mainly politics, driven by political interest. So that was very important entry point for us to generate that political interest and commitment in digitalization. So that commitment, that interest generation, it started from the highest level in the country, above the Ministry of Health. That was one of the success, I mean, factor helped us. The second was actually collaboration with the University of Oslo. It gave us a lot of power when we had this political commitment to start it, is to show them our collaboration. It was a very effective effective tools, I mean, and way to work with the ministry and demonstrate how we can approach, because digitalization is not an easy, it's a long process. But where to start, how we start, that was very much very important to address. And University of Oslo gave us the power of putting things on the right track. Because in 2015, they started individual level and few centers, few variables, and it was not sustained. So we had to understand the whole context, where to start and how to start. Plus, the sustaining the digitalization, we needed to very much pay attention to the leadership and governance, because the system is fragmented. They are not collaborating with each other, and there are a lot of wastage of resources and duplications. So for that many reasons, for example, I will just give you an example. The ministry decided to go first with the expanded program of immunization individual level. So, I mean, given the situation of Iraq having like about 1,500 health facilities providing this service with thousands of employees, it will be very difficult. So we look into what are the risks. I mean, when we had to take what are the risks that might impede the progress. So for example, I mean, we know the resistance to change is one of the biggest challenge from the previous attempts. We know that plus that risk the transition time, because I mean you don't want to create more burden, add more burdens on the people that they are doing the job on the ground. So to convince, to change the way, that's how we collectively with the University of Oslo, the experts from WHO and other partners, we made it shift to the aggregated data, and then we can slowly go. So we set the strategic vision, but the way the strategic vision was entering the data once at the facility level. So how to get there? It's a long process. And we were very lucky. I mean, preparation, it took us almost a year, from January 2022 to January 2023. It was just a preparation to set up the enabling environment for digital solution. And that was very, very important. And most importantly was how to create that governance model with at the Ministry of Health to ensure its sustainability. And then, addressing all the other areas of strategic investment, standards, interoperability, infrastructure, policies, regulation, and capacity. So similar to my colleague here, we have some principles, and these principles lie in same creation of standards, because it's not just DHIS2, we have other systems. We need to ensure that interoperable. And we ensured that local capacities are built. It's very, very important to have local capacities for DHIS2. Unfortunately, in the region, we don't have a HISP, but with the EPI program, so we started the EPI implementation for aggregated monthly data at the health facility level in February. Last week, beginning actually on 7th of June, we finished all Iraq. From in the Kurdistan region of Iraq and the rest of Iraq, we finished it. And it was very smooth. And we are very happy and proud, because we have now like a local team within the Ministry of Health from EPI. They have the capacity for data entry, validation, and quality check. So one of the big issue in Iraq was the data use. So, to ensure that this is sustained, they need to use it. If they don't use it, they will not be providing feedback, and the quality of the data can improve. The more you use it, the more you monitor, develop your monitoring and evaluation, the more data can be improved. So here, my question to other countries, we have this issue of server, local server versus cloud-based server. The ministry, we take the issue of data security and ethical issues. So it's still not easy for us as in Iraq to justify the cloud-based service. So we managed to temporarily for 3 years support the ministry with cloud-based server. But at the same time, we are in collaboration with our partner UNICEF, who's working on building a data center for the Ministry of Health. Saying that, has this problem faced any of these countries? The digitalization and how they were addressed it. I'm not a data, tech, IT person in servers, so to maybe help me enlighten us more to understand how when we talk to officials, what to say. So that's my question to my colleagues here.
Mozambique, Tanzania, Ethiopia. Do you want to try to respond to the question around the hosting? Yeah. Thank you.
Thank you so much for a nice question. Actually, we have the same challenge that he raised, but for the last couple of years, our host also, it was in the cloud, but currently we have, a strong data center at the country level. So we are working on it, and now it's working good. And we have also collaboration, because the data should be duplicated and put in different places than if there is some kind of problem somewhere. So you should find that data from some other places. So currently we are collaborating with Ethiopian Telecom, the telecommunication service. So we are hosting also in another area. So we are hosted the data in two places. One at the ministry level, we have a robust and an excellent data center. The second one is Ethiopian Telecom area. So it's also hosted there. If there is some problem in the ministry, we can access the data directly from the Ethiopian Telecom. This is the experience we had. Thank you.
Thank you. You want to add anything, Marcia or Brana?
Okay, I can share also the Mozambique experience. We had the same challenge. We still have, because normally the ideal environment is when the Minister of Science, Technology and Communications set up the data center for all the ministries. So that way you have a local server with the capacity to store all the data. In Mozambique case, that was not the case. We didn't have a legal framework to support, not even the means to set up such data center. So we came with our own data center within the Ministry of Health. So we have a physical data center with the servers, because by law we cannot storage for a long time in cloud. We can have the systems there if we are design, testing, even pilot. But once you go to implementation phase, you need to bring that information to a local government server. Okay, thank you.
Thank you.
Also in Tanzania, we had the same challenge, but when we started implementing, we were using the cloud. But after some times, as my colleagues say, in Tanzania, we have a data center whereby all information, all data are settled, stored there. So after that regulation passed by the parliament, so we decided all the information from the cloud to put at the data center. Thank you.
Thank you. Okay, Angola.
Ok, thank you. Para Angola, os dados ainda são guardados na cloud. E, de facto, pensar na segurança dos mesmos é, de certa forma, muito importante. Lógico que no horizonte temporal, não aqui frisando se é a médio, curto ou longo prazo, devemos pensar neste sentido do Estado ter os dados guardados em servidores próprios. Nós temos o Ministério das Tecnologias, que trabalha em parceria com os vários departamentos ministeriais e, de certa forma, podem-se criar soluções relativamente à conservação, posso assim dizer, dos dados que a gente tem a nível do DHIS2.
Currently, in Angola, the data are still in cloud, but this is a big challenge to bring the data to the country, I would say. So there is within the ministry a directorate that deals with issues of organizing the security of the data, but still a challenge currently now.
Okay, thank you. I think, no, I have one now, but you can have a chance later. Thank you. I know that one thing that Mozambique, Tanzania, and Ethiopia have in common is a very strong collaboration with the local universities. And I think we've that have followed DHIS in many countries have seen kind of the potential in that kind of collaboration. Can you share some insights, experiences from your countries around that university collaboration and how that has helped your implementation? I don't know who wants to go first. Yeah.
Thank you very much. Experience from Tanzania during the rollout of the DHIS2 platform, we get a very big support from University of Oslo, and that investment was done to the local institutions in Tanzania, and to appreciate and to make that system sustainable, what the government decided is to use those local universities in Tanzania to maintain the system first, also to get the innovations from those institutions, for many higher education institutions, but also in building the capacity. For example, in Tanzania, the all maintenance of DHIS2 is done by HISP group and the University of Dar es Salaam. And in the University of Dar es Salaam, what they have decided was to introduce the master's program on health informatics, which one of the components is data management, and DHIS2 is being taught. But on another hand, we have decided to introduce a curriculum on middle health cadre on the area of data management. And that curriculum involve also the learning of the DHIS2 platform. So by doing that and by using that local institution, local university and HISP group, help us much to sustain the platform, because right now the platform has grown very much the use of that platform has grown very much in Tanzania.
Thank you. Brana, Masoud, do you want to add something? Yeah, go first.
In Mozambique case, it's more or less the same as Tanzania. We've been a partner with the University of Oslo since the beginning of deployment of the DHIS2, and we had a very strong partnership with the local university. It's Eduardo Mondlane University, and this environment allows us to build capacity, to do research innovation, to have a guidance in terms of the policies, and also to start to train from early stage informatics students that can increase let's say the task force of people, staff that will in mid-long term be in the system working with the health information system and the digital platforms that we have. So it's more or less the same. It's been a very long partnership. So, and is becoming more and more strong and with impact.
Thank you.
Yes, thank you again. So in Ethiopia, in 2017, we have, health sector strategy plan, HSTP. In that health sector strategy plan, one of the transformation agenda that the sector wants to transform is the data area, which we call them information revolution. So that information revolution has three pillars. Number one, cultural transformation in terms of data quality and information use. Number two, digitalization. Number three, governance. So if we want to pass and achieve all these areas, we understand that we couldn't achieve it through the conventional way of, systems implementation. So we designed a program called Capacity Building and Mentorship Program. We call it CBMP. So we announced a kind of call from the ministry side. We had, we have like more than 30 universities. It was an open call. So out of the 30, we have selected 6 universities. So these 6 universities collaborated with the ministry with a clear vision and goal to support Ethiopian health information system, not only DHIS2. So this is the main aim is to enhance localization and local capacity. At the same time, the university to bridge the academia health sector linkage. So there are 4 collaboration areas actually we have identified. Number 1, we want them to be a capacity building hub. Since most of today's students are tomorrow's implementers or tomorrow's health professionals. So we want to integrate health information related activities in their pre-service training, so that we did that. The second one is pre-service training, I think. In-service training. So they are supporting a lot of things in doing that. The second one is they are engaged in selected districts implementation of HIS to show cases, like they create demonstration areas. So we put a clear roadmap from emerging candidate model, digital model demonstration. For each phase, there is an achievement to be done. So they did a lot by mentoring, providing supervision, something like that. The third collaboration area is Center of Excellence. So in Center of Excellence, they are supposed to be an academy for the DHIS2, number 1. They are supposed to bring innovations. They are testing different softwares. The fourth area is evidence generation. For the last 5 years, they have generated like 11 implementation research, more than 80 published and unpublished evidences from their students in other areas. So at the beginning, there was a question that whether academia versus ministry linkage was worked or not, but we proved that it's working a lot of things. We are cultivating, the results. Even at the beginning, their score was 60% on, collective score for data use information, data quality and information use, but currently it becomes like more than 85%. It's a big achievement as a country, and we are expanding the support, and currently they are supporting more than 100 waradas by 6 universities in collaboration with regions and other partners, and a lot of donors are very much interested, and they are supporting this platform as well. Thank you.
Thank you so much. I think we have one last question before we open up for questions from the audience. So we heard both from Iraq, Angola, and we know from working with a lot of countries using DHIS2 that this move from aggregate to tracker or to individual level data can be challenging. It's a lot more users, more need for support, etc. Do you have any, and we heard from both of you that this is something that it's where you want to go. Can you share some reflections? So what you think newer countries need to think about before embarking on collecting individual level data? Big question, but
so it's a big question, challenging question. But in terms of collecting individual data and implementing trackers, so currently we have relatively better infrastructure. We have good human resource at each level of the system, and we have a government commitment for the government side. And there is also a collaboration from HISP Ethiopia and other partners. So currently we have tested it in different programs, like we stated in TV, we tested it in COVID response. We are collecting individual data. So we are planning to expand in some programs like NCD and others. Parallelly, we are implementing electronic medical records. Currently, the center at Addis Ababa and other areas we are implementing. So we are preparing ourselves to have, individual level data using the DHIS2. So in terms of commitment, and since the foundation seems now very excellent, I don't think the challenges will affect that much our country, because we have a good preparation and good foundation to go ahead with tracker implementation. That's my thinking. Thank you.
Okay, thank you. Tanzania, Mozambique, reflections on
Yeah,
aggregate tracker.
Yeah, in Tanzania, we use tracker in TB program, and we have done it very well in collecting those individual data. And right now we are moving to the community level to have those individual data, but also we have used it in humanization. So based on the foundation we are having in Tanzania, we don't think that we can face the challenge, but we are moving well on that area.
Okay, it's a complex question because it's true that when you have the infrastructure already in place and you have the resources, conceptual should not be an easy task. But sometimes it's like you said, it's a big amount of users, and in our context, we have more capacity in terms of communications and network within the capitals of the cities. When you go for the more peripheral areas, then the challenge becomes even bigger, because you struggle to come with technologies that are friendly user, but at the same time you can connect easily and send the data. So our experience with the implementation of the tracker has been very challenging. We are using now in TB for some vital statistic information, and we are now moving on the community health information as well. But I think in our case, what we did to do the transition, it was because we already had the aggregated information, but the programs officials, they wanted the individual data to make sure that we are looking at the right completeness data, the quality of data, timeliness, and so on, and also to track the patient accordingly. So we try to mimic the paper system already in place, because we also have a very structured paper-based system, and in each health facility there are forms and to fill each program intervention. So we put this on tracker for these specific programs, and that's how we started to build the information flow and the data that each program needed in the district, provincial, or central level to analyze and to monitoring the performance indicators of specific programs. So it's a journey. We are still in the process, but I think so far we have some lessons that we learned that we're going to improve.
Thank you so much. Okay, I think we have about half an hour left. I think we can open up for questions from the audience. So you can raise your hand. Well, before you ask the question, great if you can say who you are. And also, if you want to address a specific country, let us know. And if it's for everyone, also make that clear so we can guide them. Thank you.
Yeah, as usual, I don't need a mic. But I'm Carl Hedberg. Been working with HISP since time immemorial. And I've been working in a lot of different countries, looked at a lot of different databases. And I think there are two major elephants in the room that you barely touched on. One is data and metadata quality, and the other one has to do with use. And I have three very specific questions for you that anybody can relatively easily pull out of the DHIS2. The first one is, in your country, HMIS, how many data integrity violations do you currently have? Does that reflect the quality of your metadata? And as I tell you, I know the answer for most of you, but that's another question. I just think this is something that everybody who is managing the systems need to know. Second question is, on average, for your aggregated data, how many of your data items, your data records, are having data quality problems? On average, just a percentage. And my third question is, out of all of your health information using managers, that's probably between 1 and 8,000. right? Is that all your health program managers, all your top managers, permanent secretaries, up to your minister. But how many of them in any random week are at least logging into DHIS2? What percentage of your health management or health information using managers are actually using the system regularly? Thank you.
Thanks, Kalle. Tough questions as always. We heard them for 25 years now. Do anyone want to respond to Kalle?
Thank you very much. That's a very good question. Very good question, but very tough. But they mentioned 3 areas are the key areas where our countries are fighting, are struggling to make it happen better. 1, the quality of data. In Tanzania, when we started collecting data by using paper-based, then we transformed to DHIS2. The quality of our data started in 2013, 14, it was almost 45%. But we struggle to make sure that our data are in a good quality and minimize variation. And last year evaluation, because in our country, each year, the internal auditor general audit our data. So in last year, the quality of our data and the quality of our data was around 96–95%. And the variation was very much minimized. Now, the challenge came. We have a lot of data with a better quality. That's come the last question. Who are using those data? Are the key, policymaker enter in the system, use the information which we are collecting? In Tanzania, I can say yes. We've managed at least 70% of decisions in health right now are based on data which have been collected. 1, procurement of medicine are much based on the data which we are collecting. Allocation of resources, we are much use the data which we are collecting. But also all plans, when we are developing health strategic plans and many plans which we are doing in Tanzania, we are trying to use the data. Right now, what the effort which we are using, it seems that the data which we are collecting are much used at the national level and the regional level, less used at the facility level and the hospital level. So we are now struggling to make sure at the facility level, they are using data. That's why Tanzania, the government have already collaborated with DHIS2 group in piloting the excellence district on the data use. So that we think when we will be able to build the capacity of the facility level, district level, how many people to use data, will we be able to achieve the last question? But in short, that's what I can share from Tanzania.
Thank you, Macha. I think we can take another question. We see you have.
Thank you, Ola. Thank you very much. Good morning, everyone. My name is Aman Siam. I'm the regional advisor from WHO for the Southeast Asia Regional Office. Thank you very much for the presenters. Your testimonies and your insight is quite useful. I'm just going to be a bit cautionary regarding the understanding of using the tracker data, the purpose of it. It's a fantastic facility in DHIS2. It has come a long way. And my only concern is when I hear that you are trying to transfer registers to be mimicking the paper-based registers into tracker. That is exactly defying, or in a way self-defeating strategy to follow. We have faced many issues in countries to try and understand how well registers are doing. Are they standardized enough relative to what we call the service standards from the service delivery point of view? And what we were challenged with is that many of these registers are sometimes collecting the wrong data. So for me, we need a dialogue on what exactly is the purpose of collecting tracker data. It's not an electronic medical record. It's not for us to measure every small detail that's needed for the patient care. It's to actually think strategically about a subset of the most essential data elements you need to follow up, or at least to understand how well care is being delivered. So it's a huge investment. It's almost a different type of skill needed. So what we need to hear from you is that you have conducted enough of a national dialogue on what exactly is needed to be measured at the patient level on account of each episode or each encounter that would be useful to exactly what my good colleague and brother from Tanzania said, the fact that I need the policymakers, the program managers to understand how well or not care is being delivered, rather than I calculate or at least measure every encounter from a lab-based result to an imagery result to this and that, because not even in high-income countries do you find any form of facility-based system that behaves as an electronic medical record, and as well as the sort of the top-level facility-based reporting of aggregates of encounters, allocation of resources, medicines. That doesn't exist, and the data is voluminous.
You want to try to formulate the question?
Yes, so the question is just, it's a very significant undertaking, and I would like to hear from each of the panelists, how well do you really understand or can articulate the need for the tracker data to be measured, given the cost of the skills needed and the quality, exactly what my colleagues have said, the data quality implications that will follow. Thank you.
Thank you. Who wants to go first?
Thank you so much. So in Ethiopia, I think implementation of tracker is tested, I think, at least in 3 programs. Number 1, in COVID response. So all tested individuals, vaccinated individuals, and others are coming through their, we are collecting the data individually. So it has many purposes, I think. The second one is for NCD. So we want to focus those individuals since they are lagging behind to get the service. We are not, removing, the paper bit. We are working parallelly. So the third one is for TB program, since there are, dropouts, so we could manage using this program. But we have an excellent example, implementation of electronic medical record at least currently in 2 big hospitals in the city. I mean, in the capital city in Addis Ababa. So they are totally paperless. We are implementing for the last 2 years. So we understand that to implement electronic medical record in the whole setting, the first thing is that leadership commitment is very important. The leaders at that hospital matters. The second one is, the capacity to have good infrastructure and other things. If you have good leadership, that is the first thing. The third one is currently the mayor of Addis Ababa is committed to implement electronic medical record and allocate a resource all facilities in the capital city. So that will make us to be, getting the data individually, improving the quality of data, the facilities, the information use. It has a lot of benefits, but what matters is leadership commitment matters. Whatever you have the resource at hand, if your leaders are not committed, you will not do anything. So, but the question is whether it is scalable to the remaining setting or not. Since Ethiopia is a big country, I don't think we'll implement electronic medical record at each corner of the country. That is the main challenge, because we do have a lot of infrastructures and leadership and resource gap. Thank you.
Thank you. You want to respond, Macha, Brana?
I think I don't have a different answer with from what my colleague have said.
Yeah, maybe we can hear from Iraq. Yeah.
Yeah, thank you very much. It was very important questions. And when I talked about the governance model, it included a special team to be institutionalized, reviewing all these forms. So because we know existing paper, it's important to mimic it, to be user-friendly, but need to ensure that the data there are not garbage in, garbage out, that it's useful for whether it's aggregated or case-based. So for both. I mean, when I link it to health system, so we need to prioritize first. Where are the problems? So for Iraq the planning is ad hoc. So resources are not. So what we need now, we need to prioritize, for example, the aggregated. That gives the picture to do high-level policies and plans for the country. But there are other low-hanging fruits in the country. If you feel it's feasible, for example, TB, we started it because we have 155 centers and we have the resources, we have the partners, and we're building the capacity, but it's a long process and it's not just a plan you set and implement it. It's evolving, changing every day. You learn from a facility to a facility. So the points you raised are very important, and it's a very contextualized answer to be, but we need to look at the root causes and how we can improve the service provision of that certain tracker if it's a major challenge or priority for that country.
Thank you. I think we can take another question. Yeah. Yes.
Good morning, everyone. I am Nader from Mercy Corps based in Pakistan. I have a lot of questions, but I would limit myself to only two. The one is, what is the key, basically, you followed for the political commitment, they're involved in everything for the successful DHIS2 implementation. Number two, there must be some areas where there's low internet services or no internet services. So how did you cater that thing? And the third question from my side, what is the mechanism? Is there any central authority covering looking after the DHIS2 or the health information system for the multi-sectors like WASH and climate change, I must say, and the health information system at the health facilities as well? Thank you.
Thank you. 3 questions. Any takers?
What the first question?
You can use one of them, maybe.
Yeah, the first one was about the political commitments, right?
Yeah.
And can you repeat the question? I didn't.
Yeah.
And can you?
So based on the success you did achieve, so I wanted to ask about, for our clarity, what was the key to involve these political people and the ministries that you successfully implemented the DHIS2 and they allocated the funds and then providing the technical support, and there's ownership from them. So
Yes,
I think now
Let's start with the first.
Thank you very much. I mean, Iraq's context, I mean, it's a very complex geopolitical situation. I mean, you have a very rapidly changing politics, and then the country, whoever comes to the government wants to demonstrate some successes on different sectors, including the health sector. So we advocated on, I mean, with the higher level politician in the country, I mean, they already have the government agenda or the program. So one of them is a digitalization. So all our role is to go there and demonstrate how digitalization will strengthen their political and enable them to demonstrate good success. So for example, Iraq, they decided to go with API case-based. So when we linked it with the politician decision makers, okay, we can achieve in 6 months aggregated data that gives you some visibility. Okay, let's go for aggregated, no case-based after 2-3 years, for example. But it's a context specific, but not easy. And then, for example, it's not just DHIS2. I answer your other question about WASH. So we have another system we are working on capturing all that information for the decision making, and we call it the low-hanging fruit. Why this? Because we need to demonstrate some successes, so that keeps the momentum and the interest of so on 7th of June, so we had launched a tool, it's a WHO HIRAMS tool. It helped us in DHIS2 actually, because all the organizational unit was brought from there. And so because of the DHIS2's interoperability, there are ways to, they are all component of HIS, Health Information System. So that keeping that interest and involvement of politicians. So the Prime Minister was invited, the whole members of Parliament were invited, and my colleagues, I mean, from headquarters and WHO Imbro. So this kind of events helps, for case of Iraq, it helps a lot to keep that political support. And then there are many other stories. Maybe we don't have time to explain, but I'm happy to share it with you.
Thank you. We have days to connect in the breaks. I think I just want to see, are there many people that have questions, so we can kind of maybe limit it to one per person? Anna, yeah, let's do a few more.
One question. All right, just a quick one. Kenneth Chimpeni from Malawi, Senior Digital Health Advisor. So I just wanted to learn from everyone, especially those that have done interoperability, especially with the tracker. So how did you work with the unique identification to make sure at least these systems are talking to each other, especially on unique identification? And maybe also, I was also interested for those that have—
One question, you need to prioritize.
Okay.
Let's start with that. You want to go first, Brana? Yeah.
Okay. I think it's a very interesting question. Mozambique is in the process of starting this adoption. One of the experience with interoperability that it's a difficult word, huh? That we have with DHIS2, it's the justice system that uses another platform. So we established an interoperability with them to share the vital statistics from the health facilities, deaths and births. And now they also were building their own system. And they introduce this number, identification number. So it's a recent project. So this year we are going to start within the mechanism that is already in place. We're going to start to collect this identification number to our system, to DHIS2. So that will allow us to really use this number to the information system at the hospitals and really be able to track, especially the chronic patients and others that we attend. Yeah.
Thank you, Brana. Any Marcia, you want to comment on the same, or yeah?
No, I mean, this process, we are also on the very preliminary stage on the unique identification. And also in Tanzania, we have one institution which is providing identification ID, national ID. So we are trying now to make interoperability between the system of national ID with the system, with the tracker which we are having, so that we can have a unique identification of those clients. But also we are now piloting also the biometric. We are on the very, very, very infant stage. So it's a process which we are going through in Tanzania also on unique identification.
Yeah. Okay, we have another question here.
Yeah. Sorry, I have the microphone.
Hi, George.
My name is George Odongo. I'm from U.S. Centers for Disease Control and Prevention. I'm happy that we have a panel composed of senior officials from the Ministry of Health. I want us to revisit the question of investment into tracker system beyond the human resources that you have explained. I do support many countries in implementing tracker system. Tracker module for notifying, submitting data, case level data for epidemic prone diseases. And I have good insights into what it costs to do that implementation. Sierra Leone is an example. In terms of the tablets, in terms of internet, not just availability of it, but the cost of submitting that data. I want to hear from different countries that are there, what strategies we are using to meet those costs, whether there is a concerted effort or commitment by the government to invest in those infrastructure that would facilitate tracker implementation in your countries. Thank you.
Thank you, George. Any takers? Jack?
Yeah, thank you very much. For Iraq, we are planning, the goal is to implement the tracker. So for that, we had to do our homework and see where we can succeed and get evidence on, like when we applied HIRAM and very shortly in 2 months, we got the picture of where are the connectivities. Like we have the connectivity in 95% of all the 5,205, for example. And then we identified where the communication equipments are. We don't know. We know if it's working or not working, but that's a very good preparation. We do it. So for sustainability, we have principles. The principles, as you said, we build on existing resources. That's our principle. So it's built on existing resources and utilize it to use the DHIS2 on that. For now, we are working also with the Ministry of Finance. What the Ministry of Finance in Iraq is exactly, is highlighting. The government, as I said, it's a rich resource country, but you need to demonstrate a success story, and you need to work and get the system is running well and increase the interest so that the government can sustain it and finance it. We know that Iraq is not, it's not, that's a two-part, Kurdistan region of Iraq and the federal ministry. So there are resources limitation in some part of Iraq. We need to consider this also. So it's a very mixed approach, but it's very critical that you take, as you said, these principles and apply it on ground to generate the interest so that it can be sustained by the government itself, by the ministries, of course, and collaboration between. You need an interest, you need an investment plan, strategy to make sure that it's sustained. But when that comes, it's a context specific and a program specific. But definitely you need to start where there are priorities and where there are good achievements can be demonstrated to get that interest.
Thank you. I think actually we'll cut you there. I have some practical information, but before I do that, we should give the panelists a big round of applause. Thank you so much. Thank you. Thank you. Thanks so much. Thank you very much. Yeah, well done. Okay, so I think I was perhaps not the only one that struggled a little bit with the agenda app and all the parallel sessions starting and ending at different times, etc. So just to try to make it a little bit easier to navigate the afternoon and all the sessions, if you go to the homepage for the conference, there's a link here now to a table, a PDF. That looks like this. So now you have kind of the different auditoriums, and then you can see when sessions are starting and ending. Okay, so that's on the homepage for the conference. Yeah, and then you can have this more tabular view, and we'll put another one for tomorrow. This is only for today. So I think Max also has some practical information.
Sure. So just to let you guys know that yesterday we did some filming for interviews, which went really well. We had maybe 12 volunteers, and we're going to do it again today, since I know a few other people wanted to talk to us. So we'll be outside in this area here between the two venues at around 5 o'clock. So if you're interested in coming to share a story with us, just come and stop by. And my colleague Jaquado will also be going around trying to look for volunteers for us. So we'll do that today at 5 during the experts lounge. Okay. And I think with that, we're done for the plenary sessions. So now it's time for lunch. So please make your way over to the cafeteria, and we'll see you at the parallel sessions at 1 o'clock.